point for infection, which is what you're worried about. I should turn this on? Is that better? Yeah. As long as the stitches are tight and not loose, there really shouldn't be any portal for infection. And that's the main concern. So as long as the surgeon said the stitches are fine, go ahead and go swimming, and it shouldn't be an issue.
Next question, I guess this would be for Dr. Lee or Dr. Kozarsky. My cornea specialist requires his DLEC patients to have cataracts removed before the procedure. What do they remove when you don't have cataracts?
Politically correct answer to that. I guess, obviously we showed some slides earlier that if the anterior chamber is shallow and there is close proximity of the lens to the cornea, with DLEC, as it first used to be described by Terry, only recommended for people with a lens implant already in place who've had cataract surgery. Now there are these new triple procedures per se, where he'll actually go in and remove a cataract at the same time and do the DLEC at the same time as well. So I guess if you don't have a cataract, probably you could have what's called a clear lens removal, which maybe some people would do, but I don't think that I would typically recommend that, or I would do that myself. I would typically only remove it if there's a cataract there. That's just the way I practice.
He's doing them without it.
Doing them without?
Dale's doing them without doing cataracts.
Okay. So you can get away with that. You just have to use the viscoelastic agents are very protective. You just have to be aware that you could maybe at a little bit more risk for a cataract to come on. But as we mentioned, you can kind of fine-tune that later on down the road by taking the cataract out later underneath the cornea and take care of any nearsightedness. It's a little bit easier to kind of correct that. So it's kind of a staged procedure in that sense.
All right, next question. I had a transplant in 2002 after cataract surgery, and now vision is diminishing. Any suggestions, Dr. Kozarsky?
Had a transplant in 2002 after cataract surgery, and vision is diminishing. There's not one answer for that. It's a whole examination and to see what's going on. Since the corneal transplant is done, you would want to make sure that the eye is getting the best correction for the corneal transplant. You'd start with making sure that the eyeglass prescription is right, correcting all the nearsightedness, farsightedness, and astigmatism. And after cataract surgery, everyone who has modern cataract surgery will get a secondary cataract. And that's something solved in 30 seconds with a laser treatment. And those would be the two major guesses. You always leave in the back of your mind that there are other causes other than the cataract and the cornea that can be causing blurred vision, as far as retinal issues and nerve issues. The most common ones are the most appropriate pair of eyeglasses or contact lens, and making sure there's not a secondary cataract.
Great. Bruce, here's one for you. How much does a corneal cost from an eye bank?
How much you got? It can be anywhere, depending on the eye bank, depending on where you are in the country. It's safe to say it's anywhere between $2,000 and $3,000 for a piece of tissue. And that's just less than it actually costs the eye bank. Now, why $2,000 at one eye bank and $3,000 at another? Charitable contributions. If an eye bank has significant charitable contributions, that reduces the amount you have to charge to recover your costs. And there are eye banks where their building has been donated to them. I have to pay $120,000 a year rent. So it makes a difference. But it is, as the people from CMS or Medicare said it's an incredible bargain, and it's much less expensive than the Alpha Core. Somebody asked how many eye banks are there. There are less than 100 now. We're one of the few states in Georgia that only has one. It's all you need. But there are several states, big old Texas has, 8 or 9. Don't need it, but they do. And we deal with only members that are accredited by the Eye Bank Association of America. So whether we provide your tissue or we have to import it to cover your surgery on any particular day, you're getting high quality accredited eye tissue.
Great. This is a good question for Dr. Lee. Working on a computer, does this accelerate Fuchs disease?
Computer work does not accelerate Fuchs. I think there was another question there about sunlight too, whether that accelerates it. And neither of those have any contribution to worsening your Fuchs dystrophy.
One thing I would say, people who work on a computer, is that when you do work on a computer, look at the screen, you don't blink as well. So you have the potential to have a greater degree of dry eye. So that's one of the things that is important. Alan, I think you might address this. Are you finding Fuchs more common than previously thought?
Fuchs is very, very common in our area.
Okay.
I think it's geographical. The occurrence of Fuchs gutata is definitely geographical, and in our area in Georgia in the southeast, it's incredibly common. It's a hard thing to miss, so I don't think it's an increasing incidence, but I'm sure there are areas in the country. I trained in New York City and saw far less Fuchs dystrophy than there is in the southeastern United States.
What could you attribute that to, maybe?
Yeah, the difference in the two is just genetic pools. Basically the population and wherever they came from in Europe or whatever, it's much, much more common here than it is in New York. If mother and father both have Fuchs, as we have, will our children be sure to have it? Fuchs is not, it's not as clear-cut as blood types. Blood types are very, easy to determine how they're going to be distributed. In Fuchs, classically, there's a 50% chance that a parent will give it to offspring. I think all of you know that. But it's not a one-for-one deal, because even though you can have the trait, you may not express it very well. So you have a 50% chance of getting the dose from a parent, but there's a lesser chance that you're really going to express it and have all the manifestations of Fuchs dystrophy.
Great. Dr. Lee, here's one for you, I think, again. Should we encourage all persons over 50 to have an ophthalmologist examine their cornea?
Right. I think the American Academy of Ophthalmology recommends an annual exam at that point, which includes visual acuity testing, glaucoma screening testing, looking with a slit lamp at the cornea in the front of the eye, in the anterior chamber, and the lens to look for cataracts, and then also to have a dilated examination to look in the back at the retina and the optic nerve. So you really should have that done once a year.
There's one addressed to me. It says, even though Fuchs is a genetic disease, have you found anything that might slow its progress? For instance, diet, vitamins, or medication? And I don't know, we haven't found anything to really slow the progress. But one of the things that I did talk about is that pool of endothelial cells out in the periphery. I mean, that's really the thing that's going to determine when a cornea is going to decompensate. So in other words, if the pool in the peripheral endothelial cells is decreasing very rapidly, then the center population of endothelial cells will decrease.
Okay.
I guess this might be a good one for Dr. Lee. Will restore lens be used more frequently now?
It definitely will be used more frequently as there's more knowledge about this. Just received FDA approval, I guess, in February or March, maybe, which means it's gone through some intensive testing clinically to make sure that it works well. As I mentioned earlier, the FDA studies which approved the restore lens did look at eyes that were healthy, meaning the cornea, the retina, the optic nerve. That was one of the limitations of the study. And so I think it's yet to be seen as to how much this will be beneficial for people with something like Fuchs in the cornea. It's just something that we'll have to learn with over time. I don't think there will be no contraindications that I can think of right now to having the restore lens if you have Fuchs dystrophy. There is a risk of glare, and that's, I think in the study, 18% in the FDA trial. So, with the Fuchs cornea, you get a lot of scatter from the light coming in. That's why many of you may be photophobic or have trouble in light situations. So that may be something to consider down the road, but I just don't think we know the full answer on that. But it definitely will be used, and I think it will become a very common thing.
Great, thank you. Alan, another series of 4 questions. I'll give it to you. I'll read the first one, and then you can handle the rest. How do you determine which one of your patients will get a lamellar procedure?
That's a hard question. I guess the question is,
Raise them up.
the question is who gets a lamellar procedure and who gets a penetrating procedure. It's an individual question, but my default answer to this is a lamellar procedure. Okay, the default answer is a lamellar procedure unless there's a reason not to. And again, a lamellar procedure is one you could have first and replace it with a penetrating procedure if you need to. And it has the safety factors of the small incision and less invasiveness than a penetrating procedure. Both work well, but there are several circumstances. If someone needs a transplant and has lots of stuff going on inside the eye that needs repair, it's easier to do that through a penetrating graft. If someone has a very shallow chamber and it's difficult to work in there, it's easier to do with a penetrating graft. But under most circumstances, I will default to a lamellar graft. Second question, what is the success rate of the lamellar procedure? Again, it depends on how you define success. If you define success anatomically, meaning how many of the lamellar patients have clear corneal transplants after, the answer is 100%. We've gotten all of our lamellar transplants clear and done. We've had 2 patients that we've had to redo where the corneal buttons just didn't work, which was a case eventually of removing the tissue and putting in a clear corneal button. We haven't thus far replaced any of our lamellar patients with a penetrating corneal transplant. If you define success in terms of vision, most all of the patients are 20/40, 20/50 or better, and that's consistent with Dr. Terry's published works where I think his average visual acuity was in the 20/50 range of all comers. And that may not necessarily be a corneal limitation. There may be other factors such as macular degeneration. But the answer is it's highly successful. Is it a 20/20 procedure in all patients? No, obviously not, but nor is penetrating keratoplasty. Is the procedure experimental or approved for clinical use? That's a great question, and it's a loaded question. Okay? The reason why I mention that is that if you go back 3 years before Dr. Terry had published a lot of his work, and he has done sensational work, and he's been very good about getting it published and having good controlled scientific research. Before that came out, you would have considered this an investigational procedure with all the consent and everything that goes into going into an investigation. At this point, there is so much good literature out, good documentation of how well lamellar procedures work. I think you have to consider it a non-investigational alternative to penetrating transplant. I think most doctors consider it that way. Nonetheless, if you ask the question another way, in terms of insurance and reimbursement for the procedure, you never want to use the word investigational. Okay? And I think I've seen this on your listserv. If your doctor refers to this in any other way other than a standard corneal transplant, you are opening up Pandora's box, basically, to go to non-reimbursement. Because the insurance companies are looking for a reason to designate something as investigational, because insurance companies are in the business of not paying for things, and you've just given them a reason to. So I wouldn't use, investigational is not warranted with this procedure anymore, and I wouldn't use that term if you're ever talking about your own care. And then, is lamellar procedure covered by Kaiser Permanente insurance? The answer is it's covered by Kaiser Permanente, it's covered by Medicare, it's covered by every insurance as long as you and your doctor refer to it as a penetrating graft, which it truly is. Okay? Only you and your doctor know that you've used a variant of a penetrating graft, but you don't want to wander to any other terminology because the government and Kaiser don't know how to deal with it.
Bruce, we have 3 questions here for you. One, can you donate your eyes with MS? Do states have reciprocal policy for donations? And how many eye banks are there in the country, which I think you did answer.
Yeah. Now, if you have MS, that is a rule out for eye donation. So we're unable to use that. Some people say, well, what about for research? Well, we can use any rule outs for research, but for me to go have our technicians recover something that I know will only go to research doesn't fit the economic criteria. We have plenty of research tissue that comes from surgical quality tissue. And I mean, bottom line, you go out and you recover research tissue, you spend $1,000 for it, and you get $100 for it. Doesn't make sense when you have enough research tissue to provide people like Dr. Edelhauser with what he needs.
Do states have reciprocal policy?
In terms of reciprocity, we deal with EBAA accredited eye banks in all throughout the country. And if on any given day we don't have the tissue to cover your surgery, we'll go to, well, I call them our go-to eye banks. We have selected ones. They're all accredited, but some are, in my opinion, more accredited than others, and that's where we go to get your tissue. And we will find the tissue. Now, somebody asked, I think at lunch, have we ever had to cancel surgeries? And I think maybe a handful a year. And that's because, for instance, I mentioned we have the 6-month-old surgery scheduled for next week. If we don't have the right donor, and we can't find it anywhere else in the country, then we have to delay the surgery. They get priority looking into the future. As soon as we get suitable tissue, they get it. But very rarely do we have to cancel because we do have reciprocity.
Thank you, Bruce. Dr. Lee, 2 questions. Does diabetes or complications affect Fuchs? And the second one, how thoroughly is Fuchs dystrophy covered in medical training for the ophthalmologist?
Tough question. First, with diabetes. Diabetes does not per se affect the endothelium of the cornea. However, it does affect the epithelium, that outer sort of skin covering of the eye. It's very notorious for causing dry eyes. It's very notorious for causing as you know, peripheral neuropathy. You may have heard that when the nerves start to get weak in the hands and arms. Well, your cornea is also a peripheral nerve. It has peripheral nerves just like your hands, just like your toes. So it can, in a sense, get a peripheral neuropathy as well, which we call a neurotrophic cornea, which means lack of corneal sensation. So that's why diabetics tend to have dry eyes, and that can be, it needs to be something considered when you have a transplant, because you're going to expect several months of a dry surface, kind of like what we talked about with chemo earlier. It's the same sort of situation. Sometimes you may even do some little tricks after the surgery to try to help that transplant heal up faster, such as some surgeons may put a little stitch temporarily in the lid called a tarsorrhaphy. So there are little tricks we can do to help you heal up quicker. Second question.
Question in regards to that, what about renal failure? Same question.
Renal failure, you really don't have anything that would hurt, other than sometimes with renal failure you can get calcium deposits on the cornea called band keratopathy. And if you've had subsequent transplants, maybe you had one and it rejected and you've had another one, you may be a little bit at a higher risk to get calcium deposits on the cornea. That's something that your ophthalmologist will see very easily. But as far as affecting the endothelium, renal failure wouldn't have any other effects. Medical school training, I think, is as Alan said, a loaded question. I think there are obviously accreditation residencies, just like there are accredited eye banks, and not every residency program has full accreditation, which is essentially 4 years. So people actually come to the site, just like they do with an eye bank, and accredit each residency and make sure that the rules are being followed, and it's something to think about if you're at a university. But most universities are well accredited for a 3-year surgical residency. There are some programs in the country that are 4 years, but the majority of them are 3 years. And Fuchs Dystrophy is covered very well. Obviously, some residencies are better, just as some eye banks are better. And that's hard to say. It's just something you may have to do a little research on. But it is covered very well, and I think ophthalmologists in this country come out fairly well schooled with this problem.
I guess this question kind of falls in my domain here. It's cell density. The person can see why cell density is very important in donor corneas in determining when to have a transplant. Many renowned doctors say that the number is not as important, but but how the endothelial cells are functioning, and that really is determined by corneal thickness. Well, I think it goes hand in hand. Cell number is important, and thickness is important. So as your cell number decreases, your corneal thickness will go up. Now it is, both of these are two good measurements to make. I mean, you can have a corneal thickness that is, say, about 0.65, or, well, that's a little high, say 0.6, and a cell density of, say, 1,400 cells per millimeter square. And, you're getting down to the edge there of where a transplant may be needed. So I think to say one is more important than the other, I would say they're both equally important. Other comments? I guess, Alan, this one fits in your domain here. With Fuchs, my vision in both eyes with correction lens is about 20/50 or 20/40 on a good day. How far down the road am I from a transplant? Also, I already have had cataracts developing in both eyes.
Holding it up, this is your prototypical Fuchs patient coming in for a consultation. 20/40 to 20/50 vision. As long as you're inside and better than driving license numbers, we don't get hung up on visual acuity. The question is, are you functioning? Okay, can you do the stuff that you want to do? How long does your early morning vision last? Is it lasting until 7:30 in the morning or 7:30 at night? And you just, if someone's impaired and it's due to the Fuchs, you go ahead and you start talking about a surgical procedure. How far down the road am I from a transplant? The answer is, are you functioning or not functioning? And you start talking about that, at least in one eye. The concept, if your function is really going away, you might as well be getting better in one eye while the other eye is getting worse, and that leaves you more options. Also, I already have cataracts developing in both eyes. If the cataracts are truly significant, using the more modern variants, the more recent variants of the lamellar procedure, it's very easy to do the cataract at the same time. It's also very easy to do the cataract afterwards. It's easy to do the cataract before. You have all three options. You really do have all three options. And again, impairment is what spells surgical treatment.
Good, thank you, Alan. Two questions, and I think this falls in Dr. Lee's, and both of them relate to the same thing, so I'll read both of them and give them to Dr. Lee. One, discuss blisters, or bullae, causes, treatment, and frequency. And the other one to you, Dr. Lee, is please mention the importance to Fuchs patients of having corneal mapping prior to developing blisters so that the implant can be selected optimally. Dr. Terry had to guess on mine because he couldn't get the mapping because of my blisters.
Well, you had a good one there, so you probably guessed right. But, so why do blisters form, or bullae? We saw it nicely described early on those corneal pictures where the endothelial cells were loosely adherent and fluid could escape through there. We also talked about the immigration pressure and the swelling pressure as far as keeping the cornea thickness down. All those things are distorted in Fuchs dystrophy, and so fluid rushes into the cornea. When the cornea holds a certain amount of fluid, it's like it tips over like a I guess in a sense, a drain in your sink or something that's just flowed over. Same way in the cornea, the epithelium, that outer layer, can't withstand a certain amount of fluid in the cornea. And if you pass that level, that's when you start to get those cells to swell. And when they swell, just like a blister on your hand, if you've been working in the yard or something, it swells. The same thing on your cornea. And those blisters can be burst and be painful just like a blister on your skin. So that's really why they develop, is based on the amount of water content in your cornea. And that's one of the things that the Miro helps. It's an osmotic to try to draw that fluid out. Some people even will tell you about a hair dryer to do, which is, just don't be careful with that. As far as the lens implants, you certainly could do that. You could, I mean, I pretty much get a corneal topography on basically all my new patients just because I want to have that data, because you never know what's going to happen down the road. Everyone is different in regards to that opinion. That's just the way I was trained. It's nice to know data down the road, even with these, when we do LASIK, now it's important now, if you have cataract surgery down the road, to know about what your measurements were before. So we're pretty good about that now, and all our new patients getting that data, and as much data as you can have, the better. But there are formulas, and there's a lot of research that has been done in the past with predictions for IOL powers. Many people have done papers on predicting the lens implant with this triple procedure. And so there's an estimated number that we can use to help us figure that out, and that's probably what he used. And it's not perfect, but sometimes you just can't get a good picture to do it. With that answer.
Great. Bruce, one's come up your way here. Can someone who has had cataract replacement later donate corneas to the eye bank?
Yes.
Short and sweet. Next one, I guess, Alan, this may fall into yours. If a Fuchs patient requires a corneal transplant, is there any danger of the tissue rejection in a patient with a history of severe allergies?
Does a bad allergic history negatively prejudice a corneal transplant because of the possibility of rejection? The answer is probably slightly yes. If your immune system is very active and you're very reactive to external allergic producing stuff, you're probably more likely to react to a corneal transplant, and that would probably be a cue to the doctor to keep someone on a baseline level of anti-rejection eye drops. Could probably be controlled pretty easily.
Dr. Lee, this one will kind of fall in, we'll just kind of divide them up here. For those who need corneal transplants at a younger age, will there be a need for another corneal transplant after many years, or is this even possible? Well, let me just say, Bruce mentioned that he had a corneal transplant 40 years ago for keratoconus, I think, at that particular time, and it's still functioning very well. But for Fuchs patients, this may be a different story, and I'll let Dr. Lee answer that question.
And that kind of can be addressed back to those peripheral endothelial cells too, which are probably degenerated with time. So even with this new transplant, you probably will be at more risk versus a disorder like keratoconus. You'll be a little bit more susceptible. Right. Well, right. This is probably one of with any kind of, there are different endothelial problems, Fuchs being one. So I would say any of those disorders are at a higher risk of needing another cornea transplant down the road. Having said that, Dr. Castro-Viejo's counterpart on the West Coast was Max Fine, and I had the pleasure of seeing a lot of his square grafts as well in my fellowship. And I can remember one in particular who had a Fuchs transplant in 1952 with a square graft who was clear as a bell. So there definitely are different cases, and it depends on the donor tissue, the endothelial cell count, and then your peripheral endothelial cells as well. So a lot of things can go into that.
Alan, a couple questions here. I'll read them. Why wait for the transplant? Why not go ahead now? And the other one is, what prevents need for a second corneal transplant?
Two more loaded questions. Why wait for the transplant? Sophisticated medical principle. If it's not broke, don't fix it. The main thing is that nothing that we do is perfect, and you always have to weigh benefit against risk, and everything has some risk to it no matter how good we do it. And to wait for the transplant is reasonable, again, as long as you're functioning well and you're not visually impaired. And if you are impaired, then it's time to have a transplant. But surgery is not something you want to do preemptively. You really want to make sure that you fully develop the surgical problem that you're fixing. What prevents the need for a second transplant? As in, how can I just have one transplant and not have it repeated? I guess part of that is in Brutus's area, and basically getting, did someone mention quality? And, you know, Hank's area in Dr. Edelhauser as far as preservation of tissue, and the more endothelial cells that you can deliver via the corneal transplant, via the eye bank, via Hank's knowledge, being surgically gentle and some good luck, the more time you have against the slow depletion of cells over time. So all those factors are important. And I guess that would be the only thing that I could say to prevent a second transplant, other than the precautions that we talked about with your first transplant, and never be in denial of any issue you're having with a transplant, but just treat it then and there, because most of them are fixable.
Great. Dr. Lee, this falls in the area of corneal external disease. What causes my eyes to be red on the lids?
Boy, many things. Allergies can cause redness in the eyes. Classical teaching would say if you have itching, probably a component of allergy. No itching, no allergies. That's something to think about if you have itching components. You may have allergic findings. One thing that's very common that's easily missed by ophthalmologists, because we're ophthalmologists, is rosacea. Finding in the facial features, which causes a lot of what we call brush marks, which are little red marks on the eyelids. So that would be something else that you could think about. I guess conjunctivitis, just whether you have blepharitis, which blepharitis is an inflammatory condition of the eyelids, where the oil glands can get blocked and lashes can get matter developing on them. I'd say blepharitis and rosacea are probably the most common two that I see, and then allergy and infection maybe down lower on the list. So.
This one was addressed to me. It said, as a child I had a lot of trouble with pain. Maybe it was because of dry eyes, and I was treated with a steroid ointment for about 2 years. Could that have hastened my development of my Fuchs dystrophy? I don't think so. I think that you're dealing with a kind of a genetic component in what's happening with the peripheral pool of endothelial cells and the absolute number of endothelial cells. So being treated for dry eye or with steroid ointment should not have an effect on enhancing the rate of the Fuchs dystrophy. Any other comments? Okay.
And that's pretty much the main thing that.
All right, then the last two we have, which fall into what Alan has talked a little bit, and I'll read both of them and then let him answer in the direction that he wants to go. One is, how is the interlace machine used for transplant surgery? And the other one is how DA-LEC versus DS-LEC, and compare the two. So I think this is the strippers and the
Yes, sir. Interlace machine. Interlace is a laser that was developed for the use of LASIK, which is fairly useful in that you can create that partial thickness incision that you saw us making in the film and do it with a laser. The interlace, and the answer is we would always want to have something automatic and mechanically done as opposed to surgeon done if we're better and it was repeatable. The interlace works great with LASIK, in which you have a layer just very superficial in the cornea, just 100 microns into the cornea. When we would do a deep lamellar procedure of any kind, it needs to be about 400 microns deep in the cornea just so you separate off that back layer. The interlace has been very difficult to use that deep in the cornea. But if they perfect it enough that we can make a laser incision that deep, do the separation by laser, we'll be the first ones to buy it because it's a very tedious chore. It leads to the second question. The DSLEK, which I would assume in the alphabet soup, is deep automated stripping lamellar keratoplasty versus DS. And what some of the doctors are doing now is to use the mechanical device that we use during LASIK to create that layered incision. And that can be done. And it's probably a good idea if you have a machine that can do it reliably. One of our great fears is ruining a donor tissue. Okay, that is a huge fear. It's a terrible thing. You know, we talked about how important donation is, and in our series, I think, Bruce, you may or may not know, in doing 50 DLEC operations that we have done, lamellar, we've probably ended up using the second donor on maybe 3 of them. Okay, that means that we're 3 donors that we used that had to be discarded, and we used the second donor to actually make the button. To use a mechanical device now to do that separation, I think has a greater chance of making a donor unusable. And that's our fear in doing it. We're all LASIK surgeons as well as corneal transplant surgeons, and we know how to use these devices, but to use it on a donor is sort of a hit and miss kind of thing. From the patient's standpoint, 6 of one, half a dozen of the other. From the surgeon's standpoint, to use these devices is much easier than to do it by hand like you saw in the films. But our fear is that if the machine and the donor don't like each other, you've wasted a donor, and that's a terrible loss.
Well, I thank the panel here, and I'll turn the microphone over to Signe. And I think the questions you had were excellent.